Hi, my name is Amy Dickey, and I'm doing a recording of the talk on evidence-based consensus guidelines for EPP and XLP that was given at the International Porphyrias Symposium at the end of October. It was for the EPP patient meeting. And I'm doing a recording of the talk so that those who weren't there can be able to have this information as well. I'll share my screen. And I'm an assistant professor at Massachusetts General Hospital and Harvard Medical School. And as many of you know, I have EPP myself. Here are my conflicts of interest. And just as a background, EPP was first described in 1961, and since then there's been over 2,700 research articles that have been written about EPP and XLP, but for the non-expert, this literature is very difficult to digest with a lot of conflicting information. So the objective of this study is to develop evidence-based practice guidelines for the diagnosis and management of EPP and XLP. The audience for this project were general dermatologists, primary care physicians, hepatologists, general hematologists, so that doctors taking care of EPP patients who may not be porphyria specialists would know how to take care of patients with EPP. There aren't a lot of EPP experts across the US, but every patient with EPP should be able to get appropriate care. So the methods of this study is that we first got together to decide on a topic and writing committee, the different experts that we're working together to write this project. We then determined the scope, clinical objectives, and draft an outline. Then we assigned writing committee, assigned each writing committee and the roles, and then we defined and conducted the literature search, distributed articles to the different committees of doctors of various specialties, and I'll go through each of these steps in more detail later. And then each writing committee evaluated the articles that were assigned to their committee. So each committee had a different topic to look into, general topic, and articles assigned to them. So they looked through read through the articles, then they wrote recommendations based on those articles and assigned strength of the evidence for each of their recommendations. Then within each writing committee, and then among all the writing committees as a whole, we needed to come to consensus about the guidelines. So this happened through a series of voting and discussions, first within the writing committees and among the committees as a whole. Then we wrote the articles and made tables and figures and submitted for publication. There were actually two publications that came out of this work, one on general guidelines for EPP, XLP management, and one was specifically geared to liver dysfunction in EPP and XLP. So first, to tell you a bit more about the literature search itself, there's different research databases where doctors and researchers can go to find articles about different topics. PubMed, Embase, Web of Science, these were the different databases that were searched. And the search terms were very general because we didn't want to narrow ourselves and then miss articles. So we searched for anything about EPP or XLP. Next, and we wanted to include things that were related to the diagnosis and management of EPP or XLP and things that were a human or animal study. We wanted to include some high quality animal studies because EPP is a rare disease and not everything has great human research in it. And we wanted to exclude things that were not available in English, things that were conference abstracts, so not really complete studies. And also non-primary research. Essentially, non-primary research are things that are summaries of other research. And all of the articles were reviewed by two different reviewers to first the abstracts were reviewed to say yes or no, and then the things that was a yes or a maybe, the full articles were reviewed to say yes or no. And if there was any conflict between these two reviewers, there was a third reviewer that resolved the conflicts. And the articles were divided into the committee topics, the different topics that we were interested in, and placed in folders that all the committees would have access to. There was Mendeley is a program where people can share articles amongst each other in different folders. So that's what we used. And the different topics were diagnosis, skin, liver, blood, and psychosocial miscellaneous. So those 5 different topics. And to tell you a little bit more about levels of evidence in research, there's some things that carry a lot of weight and some that are useful but don't carry a lot of weight. And we had to evaluate the articles based on the level of evidence here. The systematic review at the top is the highest level, the best level of evidence. And those are things are basically research publications that summarize many different randomized control trials to tell you the overall effect of many randomized control trials together. The next is a randomized control trial where you have some people on placebo, some people on the study drug, but no one knows who's on what. Then there's cohort studies where there's just a group of patients taking a medication or have some exposure. And then case control studies where some people have an outcome, other people don't have an outcome, and you go back to look at exposures. And then there's case series or case reports where you have a few patients that you're reporting on together, such as, hey, I have a cool patient. Let me tell you about the patient. I tried this medication on this patient. This is what happened. That's what case series and case reports are. And then editorials or expert opinions are just someone saying that they're a porphyria expert. They've seen a lot of patients. This is what they think is best. So these are the way we essentially classify the research. Over here, level A, B, and C is based on what I just talked about. Multiple populations evaluated, multiple randomized controlled trials and meta-analysis, basically the top of that pyramid. Level B is a single randomized controlled trial or non-randomized studies. And level C is if you have just expert opinions or some case reports. So because porphyria is a rare disease, most of the data is on level C or sometimes B level. We really don't have any level A level evidence because it's such a rare disease. And then at the top, the class is whether or not basically benefit versus risk of that recommendation. So class 1 is the benefit is much, much, much greater than risk. Class 2A, benefit much, much greater than risk. Class 2A, benefit greater than risk. And then class 3 is it's not recommended, the risk is too high. So just to note here that recommendation can be anywhere on this chart. So something can be strongly recommended, but with very little evidence depending on the situation. So something can be class 1C. So for this study, here is the Porphyria Guidelines Committee. The chair is Manisha Balwani, who's a porphyria doctor at Mount Sinai. I was the co-chair, had a document manager, and the research analysts who were working on the literature review that I talked about. And then we have the different writing committees. So these are groups of doctors, researchers with different specialties. So people were assigned to different committees based on their specialties. So the liver committee was mostly liver doctors. The hematology committee was mostly blood doctors. The dermatology committee was dermatologists. the diagnostic testing. These were people who were interested in that topic, and and so on. So we had a group of people for each topic, and each group of these doctors received a set of articles that were pertaining to their topic. Okay, so for the results, we, as I mentioned before, we started with over 2,700 articles. Well, actually, only 1,400 articles have been written for EPP because they removed duplicates in the first round, and after then records were excluded based on the inclusion-exclusion criteria that I mentioned before, whether or not it was related to diagnosis or treatment of EPP, whether or not it was accessible in English, and whether it was a conference abstract, etc. And so we ended up with 268 articles to review that had to do with diagnosis and treatment of EPP. And of those, 81 were related to diagnosis and management of EPP-related liver management, which was the topic of a second article. And I'll go through some of the figures we used for this publication too, just to, in addition to wanting to give recommendations to doctors, we also wanted to provide a good overview of EPP. And so here is a diagram of the heme biosynthesis pathway, where EPP is a defect of the last enzyme of heme synthesis. X-linked protoporphyria is a gain-of-function mutation of ALAS2, the first enzyme of heme synthesis, and both of them lead to the overproduction of protoporphyrin IX that causes painful light sensitivity. Here are also some pictures that we included in the review, and thank you to many patients who agreed to provide pictures for this publication. We have some kids and some adults, as you can see, and we also have a picture of a very normal looking hand having a reaction, also just to emphasize the fact that in EPP your skin can look completely normal even when you're in severe pain. Here were some first set of guidelines, and in the pictures for the tables for the publication, we color coded it based on the level of evidence. And so this table is about diagnosis and monitoring, and class 1 level B, so benefit much greater than risk but limited published data, is that for diagnosis of EPP, we should rely on a total erythrocyte protoporphyrin test with an elevated, that's predominantly metal-free erythrocyte protoporphyrin rather than zinc erythrocyte protoporphyrin. In the publication, we talked about how there's a lot of labs that do it incorrectly, so it really should be done at UT Medical Branch or Mayo, because many labs in the US don't do this correctly and actually test only zinc protoporphyrin, which can be normal in EPP. Also, for genetic testing of EPP, the goal is to distinguish between EPP and XLP, is to look for variants in ferrochelatase and ALAS2. And the percentage of metal-free versus zinc-bound protoporphyrin can also help distinguish between EPP and XLP. Next, in terms of what should be monitored at least yearly, the total erythrocyte protoporphyrin, liver function testing, hemoglobin, iron panel, and vitamin D should be monitored at least yearly, because patients with EPP have a risk of liver disease. Very big changes in protoporphyrin can also signal issues with the liver. Patients with EPP can have low iron or low hemoglobin. And because of the light protective practices of EPP patients, vitamin D deficiency is very common. And for patients on afamelanotide or Scenesse, whole body skin exams every 6 months is recommended. Things that are not recommended for diagnosis: plasma porphyrins, urinary porphyrins, fecal porphyrins, skin biopsy are all not recommended. And notably, urine porphyrins and fecal porphyrins are often completely normal in EPP, and plasma porphyrins they also can be normal in EPP, so not to be used for diagnosis. Next, as for EPP XLP management, there were a lot of medications that had been tried for EPP in different small studies and clinical trials over the years, this whole big list in gray here. But based on the evidence, we couldn't recommend any of them for EPP except for afamelanotide or Scenesse. So things that had been tried for EPP, beta-carotene, cysteine, cimetidine, isoniazid, warfarin, all of these. It's not saying that any of these are not effective. They may be, but we need more evidence for whether or not they're effective or not. The things that did have evidence for them was Scenesse for EPP and XLP. Also, of course, sunlight avoidance, sun protective clothing, patient support groups, and also light filters for prolonged surgeries. Next, in the Class 1A Level C category, which is basically benefit greater than risk, but very limited data, is things like window tinting for cars, broad spectrum sunscreens, like opaque sunscreens that block visible light to some degree, workspace school accommodations, educating teachers about EPP, XLP, helping children explain their disease. All of these things are likely beneficial. There's not great evidence for it, and it may be patient specific as to whether or not some of these things are beneficial or not. Next, with less evidence is using indoor lights that have minimal blue light. Furthermore, for those patients who are not a candidate for afamelanotide, things that could be considered is UVB phototherapy. So going to a doctor's office where dermatologists give a specific wavelength of light that has a minimal amount of the wavelengths that EPP patients are sensitive to build up a tan that way. Also, gradually increasing sunlight exposure over time. Both of these have risk in terms of risk of melanoma with increased sunlight exposure. Also, it being unclear to what extent patients can get some of these treatments without getting EPP reactions. So afamelanotide is preferred over those if people are not, but those can be considered if people are not able to get afamelanotide. Next, in addition for EPP XLP management, for management of phototoxic symptoms, really the only thing that has some evidence is cool compresses or cooling devices. There have been a lot of things tried, like narcotics, steroids, antihistamines, Tylenol, ibuprofen. All of those don't have any evidence of being beneficial. As an EPP patient myself, I really wish there was something that could help once the pain starts, but that's a really big unmet need for EPP and something that I hope to investigate in the future. Next, for patients who are iron deficient and have EPP, there's conflicting information about whether iron is beneficial or not. Sometimes excess iron can make people make more red blood cells and the protoporphyrin can go up, worsening light sensitivity. So in EPP, we want people to really need the iron, display they need the iron before prescribing iron. So for EPP patients who have iron deficiency, we tend to wait for the hemoglobin to be less than 10, ferritin less than 10, and then supplement iron to a goal of ferritin 50 to 100. In XLP, on the other hand, there's more evidence to suggest that iron could be beneficial rather than harmful. So for XLP patients who have any iron deficiency, they should be supplemented with iron. For patients without any known liver disease, to prevent liver disease, it's recommended for EPP patients to avoid excessive alcohol intake and to be immunized against hepatitis A and B. And for screening ultrasounds, there's no evidence that it's beneficial. And for pregnancy, there's no evidence for excess risk in EPP with pregnancy. So pregnant patients with EPP should just get regular EPP care and also regular pregnancy care. Nothing should really be changed because they have EPP. If there's many patients with EPP who actually say that they have improved light sensitivity when they are pregnant, which is really interesting. Next, as I mentioned, there was a publication also about liver management of EPP and XLP, evidence-based guidelines for liver management, EPP and XLP. And this is a figure for that paper, which basically shows that protoporphyrin goes out of the marrow and into the liver. And in the liver, it can basically damage the liver cells, especially the cells in the ducts of the liver. And here's a figure of the different recommendations for liver disease. Here on the left is for those with mild to moderate liver disease, and on the right for those with advanced liver disease and failure. So for the mild moderate category, for workup, any patient with any mild moderate liver disease and EPP should be worked up for other causes of liver disease, because just because someone has EPP doesn't mean that their liver disease is necessarily from EPP. They can get liver disease of other types too. So here is some list of testing to look for viral causes, to do an ultrasound of the liver, to test for different immunologic causes, and then also to do a biopsy if there's continued concern. Next, for monitoring, for those who have mild to moderate liver dysfunction, the liver function labs should be checked at least every 6 months, and they should get an abdominal ultrasound and also a test to look at the stiffness of the liver called liver elastography. In terms of management, there have been several things that have been tried, but without great evidence. However, the benefits are likely greater than the risk for many of these. For class 2A, which is risks or benefits much greater than risks, that would be ursodeoxycholic acid, cholesterol, cholestyramine, vitamin E. So all of these things are antioxidants that can potentially help the liver, also help clear the protoporphyrin from the liver, theoretically. Also, alcohol abstinence is recommended for this group, and it's also recommended to avoid high-dose estrogen oral contraceptives that can also slow the flow of things through the liver. And then it's also recommended for patients to be referred to a center with expertise in porphyria to help with management. For those with advanced liver disease and liver failure, it's recommended for people to be referred to a transplant center, to people who have expertise in porphyrias. There's a high likelihood that patients who develop liver failure, advanced liver disease, and EPP will need a transplant. There's a lot of temporizing methods like filtering out the red cell or exchanging the red cells, giving blood cell transfusions, giving IV hemoglobin, filtering out the plasma. But all of these things are just temporizing measures to help people get through to transplant. And there may, in some cases, a stem cell transplant after or sometimes before a liver transplant may be useful. However, there's not very much data about which patients this is best for, or whether it should be before or after the liver transplant. There's a lot that's not known about liver management in EPP. Okay, and like I said, there's been 2 publications already about evidence-based consensus guidelines for EPP. The first paper was published in the Journal of American Academy of Dermatology in 2022. And the second paper on liver disease guidelines was published in the Journal Hepatology in 2023. So we're all very proud about these papers. And if you're interested, I'm sure you could reach out to the United Porphyrias Association to get copies of these publications to give to your doctors. And here's, again, a summary of some of the recommendations that I already went through. So diagnosis is elevated erythrocyte protoporphyrin greater than 3 times upper limit of normal. That's mostly metal-free. If it's mostly metal-free, predominantly metal-free, it is generally EPP. And if there's greater amount of zinc protoporphyrin, like in the 50 percent or 15 to 50% zinc protoporphyrin, that's generally XLP. And these can be separated by mutations. EPP with ferrochelatase mutations, XLP with ALAS2 mutations. Again, for monitoring, measuring total metal-free protoporphyrin, plasma porphyrins, CBC, which is complete blood count, looking at the hemoglobin, liver biochemistries, iron studies, vitamin D level, and then sometimes liver imaging if needed, and that people should be counseled about their limiting light exposure, which most patients with EPP have figured that out very well on their own, and then afamelanotide, and then there's a lot of clinical trials going on now for EPP, and so those should be considered as well. Okay, here's acknowledgements. Basically, everyone who was part of this publication. A thank you to the United Porphyrias Association. Feel free to reach out if you have any questions. And it was a really fun and meaningful project to work on, and I hope it's helpful for you and your doctors to have these evidence-based guidelines for EPP and XLP. Thank you very much. Take care. Bye.